My proposed program is to look at peripheral arterial disease, which is the leading cause of amputation in America. And I want to develop an AI-enhanced way of doing diagnosis without having to go through clinicians. In peripheral arterial disease, we have a lot of diagnostic challenges. So at the population level, there's a huge challenge because we don't have asymptomatic screening. So at the operational level, we develop frameworks for assessing model capabilities, as well as fine-tuning those models if they're found to have poor accuracy or poor alignment. We develop some frameworks that allow us to better assess and hone in on where the problem is, and then deal with that through a variety of technical solutions, such as supervised fine-tuning, through instruction tuning. We developed the pipeline that allows us to break up a provider note into various different components so that you have more efficient model training. The challenge there is the input data is only as good as was recorded as data artifact. If they didn't ask it previously, or they did ask it but didn't record it, then it's not there and it's unavailable for training. So that was one huge problem that we discovered. The second was that models are very good at determining peripheral arterial disease, which if you had the data, could a model diagnose peripheral arterial disease, at least to the level where you could ask a clinician, hey, do you agree with this? Models are very capable of that. We found that the model does not behave poorly, but what is recorded does tend to be different for minority patients versus majority patients, with minority patients having a higher tendency for incomplete and fragmented healthcare. When we're building the system up front, we bake into it these considerations that the capabilities and information from it might be used for various different interested parties. So our next steps in our lab is to take this fine-tuned model and put it in a format that can be deployed in the setting of a digital health intervention. We want to actually run a clinical trial to see if it changes provider behavior along the spectrum of efficiency. Does it improve patient safety, and does it improve completeness of workup and recommendations? And then from the patient side, are we able to use this language model to generate any patient-facing information that would allow them to basically have a better understanding of their disease? But in 10 years, I hope to be able to scale either horizontally into other diseases that have similar problems, or vertically into other capabilities, so that we really pioneer a model where clinicians and artificial intelligence or machine learning enhanced tools work seamlessly together. I think that this holds a promise to make clinicians a lot more efficient. I want clinicians and machines to be able to work together seamlessly in a way that enhances both our capabilities and our capacities to treat patients and make them better. I think that when we can get to the point where you're bringing the knowledge and expertise from the clinical side of the house and the informatics side of the house together, only then can we get this rapid acceleration and innovation that we're all hoping for.